Now let's get on with chapter 10, which is the final chapter in ANS pharmacology, that is about adrenoceptor blockers or sympatholytics. So alpha and beta adrenoceptor blocking agents are divided into primary subgroups on the basis of their receptor selectivity, that is whether they are selective for alpha receptors or beta receptors. So all of these agents are pharmacological antagonists or partial agonists and are mostly reversible and competitive in action. So because alpha and beta blockers differ markedly in their effects and clinical applications, they are considered separately. So coming to the classification, so alpha blockers, few are non-selective and the rest are selective. So non-selective ones, based on their competitive or reversibility, competitive nature or reversibility, they're classified into irreversible and reversible alpha blockers. Irreversible, we have phenoxybenzamine. Okay, there's an A sound, right? Phenoxy, irreversible. So irreversible, phenoxybenzamine. Reversible, we have phentolamine. Amine kind of sounds like again. So you can again it can act. So again you can regenerate something like that. So again phentolamine, again phentolamine. And then we have alpha 1 selective drugs which include prazosin. So prime, one is prime, right? So it kind of sounds like prime, spra. So alpha 1 selective prazosin, and y is 1 prime. Okay, so 2 is like y is 1 prime, so 2 y yohimbin. Okay, then afterwards we have beta blockers, which include non-selective beta blockers such as propranolol, and we have beta 1 selective. A is the first letter in the English language, so we have atenolol, and B is the second letter in the English language, so we have beta 2 selective, we have butoxamine. Okay. So coming to the classification of alpha blocking drugs, subdivisions of the alpha blockers are based on selective affinity for alpha 1 versus alpha 2 receptors or a lag thereof. Other features used to classify the alpha blocking drugs are their reversibility and duration of action. So we have phenoxybenzamine, which is irreversible, E, and it is long acting because the name is quite long. Okay, and it is a prototypical long acting alpha blocker. It differs from other adrenoceptor blockers in being irreversible in action. It is slightly alpha 1 selective. Coming to reversible shorter acting drugs, we have phentolamine, whatever. Again, so it is competitive reversible blocking agent that does not distinguish between alpha 1 and alpha 2 receptors. Then alpha 1 selective, we have prazosin, which is a highly selective reversible pharmacological alpha 1 blocker. We also have doxazosin and teratosin and tamsulosin, which are similar drugs. The advantage of alpha 1 selectivity is discussed in the following text. We have alpha 2 selective drugs, yohimbin and rovulsine, which are alpha 2 selective competitive pharmacological antagonists. They are used primarily in research applications. So now coming to the pharmacokinetics. Alpha blocking drugs are all active by the oral as well as a parenteral route, although phentolamine is rarely given orally. Okay, so phenoxybenzamine has a short elimination half-life but a long duration of action. See, if something acts for a long amount of time, you don't want to eliminate it, right? So it has a short elimination half-life. Okay, so that is quite the paradox. So short elimination half-life, but it has a long duration of action. Because it binds covalently to its receptor, it is irreversible. Phentolamine has a duration of action of 2 to 4 hours when used orally and 20 to 40 minutes when given parenterally. So phentolamine, okay, phentolamine, amine sounds like, again, so again you can get it. It is a reversible non-selective alpha blocker, but at the same time, if you give it orally, so it has an action of duration of action of 2 to 4 hours, and given parenterally 24 to 40 minutes. So 2 and 4, and these numbers they keep repeating in case of phentolamine. So amine, again these numbers keep repeating. Prazosin and the other alpha 1 selective blockers act for 8 to 24 hours. So prazosin prime 1 alpha 1 receptors and also alpha 1 selectivity, and also 1 for 1 day. So 1 day is 24 hours. Okay, so 8 to 24 hours. Coming to the mechanism of action, phenoxybenzamine binds covalently because it is irreversible. It binds covalently to the alpha receptor, thereby producing an irreversible or insurmountable blockade. The other alpha blocking agents are competitive antagonists, and their effects can be surmounted or overcome or competitively overcome by increased concentrations of the agonist. This difference may be important in the treatment of pheochromocytoma, which is an adrenal medullary tumor, because a massive release of catecholamines from the tumor may overcome a reversible blockade. Let's just discuss a few high yield terms. So, what is a competitive blocker? It is a surmountable antagonist, one that can be overcome by increasing the dose of the agonist. So, what is epinephrine reversal? Conversion of the pressure response to epinephrine, typical of large doses, to a blood pressure lowering effect caused by alpha blockers, which unmask the beta to vasodilating effects of epinephrine. So, that is epinephrine reversal. So, you are reversing its actions. So, epinephrine normally has a pressure action, and reversing those effects because of unmasking the beta to vasodilating effects, which eventually leads to a blood pressure lowering effect caused by alpha blockers, that is epinephrine reversal. So, intrinsic sympathomimetic activity ISA, partial agonist action by adrenoceptor blockers, typical of several beta blockers, example pindolol and acebutolol. So, we have irreversible blockers, which are non-surmountable inhibitors, usually because of covalent bond formation. We have phenoxybenzamine. Membrane stabilizing activity, or MSA, they have local anesthetic action, typical of several beta blockers again, for example propranolol. So typically we have intrinsic sympathomimetic activity of several beta blockers such as pindolol, and membrane stabilizing activity propranolol. And orthostatic hypotension that is most marked in the upright position caused by venous pooling, typical of alpha blockade, or inadequate blood volume caused by blood loss or excessive diuresis. Partial agonist, a drug such as pindolol that produces a smaller maximal effect than a full agonist and therefore can inhibit the effect of a full agonist. And pheochromocytoma, it is an adrenal medullary tumor consisting of cells that release varying amounts of norepinephrine and epinephrine, such as catecholamines, into the circulation. So coming to the effects of these alpha blockers, we have non-selective blockers. These agents cause a predictable blockade of alpha-mediated responses to the sympathetic nervous system discharge and exogenous sympathomimetics. So the most important effects of non-selective alpha blockers are those on the cardiovascular system. A reduction in vascular tone with a reduction of both arterial and venous pressures. So if you block alpha receptors non-selectively, so there is a reduction in both arterial and venous pressure. So you are lowering the blood pressure in both ends. There are no significant direct cardiac effects. However, the non-selective alpha blockers do cause baroreceptor reflex mediated tachycardia as a result of drop in the mean arterial pressure. So you're blocking the sympathetic nervous system. What you expect is a fall in the BP, right? So a result of the drop in the mean arterial pressure. Okay. So non-selective alpha blockers do cause baroreceptor reflex mediated tachycardia. So you expect a fall in the BP, bradycardia. Sorry, heart rate, bradycardia. But then what you actually find is there are baroreceptor reflexes that immediately combat this fall in heart rate. So immediately you become tachycardic. And this tachycardia may be exaggerated because the alpha 2 receptors on the adrenergic nerve terminals in the heart, which normally reduce the net release of norepinephrine, are also blocked. So there is no reduction in the normal release of norepinephrine. Okay. Coming to epinephrine reversal, it is a predictable effect in a patient who has received an alpha blocker. The term refers to a reversal of the blood pressure effect of large doses of epinephrine from a pressor response mediated by alpha receptors, because you're blocking those alpha receptors, to a depressor response mediated by beta receptors. Beta 2 receptors mediate depressor responses. Okay. The effect is not observed with phenylephrine or norepinephrine because these drugs lack sufficient beta 2 effects. Epinephrine reversal manifested as orthostatic hypotension is occasionally seen as an unexpected but predictable effect of drugs for which alpha blockade is an adverse effect. For example, some phenothiazine, antipsychotic agents, antihistamines, etc., which is actually shown in this figure. Okay, so epinephrine in large doses, the alpha action happens and there is a net pressor effect. Okay, so there is a net pressor effect, but in okay, so before alpha blockade and after alpha blockade there is a net pressure effect, but then after alpha blockade there is a beta 2 receptor mediated depressor effect. Okay, so what was like this now becomes like this. Okay, so when you suppress that pressure effect, it becomes like this. So this is combated by this and finally it becomes like this. So that is what is mentioned here. So coming to selective alpha blockers, because prazosin and its analogs block vascular alpha 1 receptors more effectively than the alpha 2 modulatory receptors associated with cardiac sympathetic nerve endings, these drugs reduce blood pressure, which much less reflects tachycardia than non-selective alpha blockers. These drugs also have useful relaxing effects on smooth muscle in the prostate. Okay, so alpha 1 blockers, sorry, the non-selective alpha blockers, what happens is they are supposed to block sympathetic activity, so you expect bradycardia, but because of reflex actions from the baroreceptors, you get tachycardia. But coming to selective alpha blockers, because they are not as, uh, encompassing as non-selective ones, which act both on alpha 1 and alpha 2. The selective ones, the reflex tachycardia is much less. Okay, so coming to the clinical uses, coming to non-selective alpha blockers. Non-selective alpha blockers have limited clinical applications. The best documented application is in the pre-surgical management of pheochromocytoma. Such patients may have severe hypertension and reduced blood volume, which should be corrected before subjecting the patient to the stress of surgery. Phenoxybenzamine is usually used, an irreversible drug is usually used during this preparatory phase. Phentolamine is sometimes used during surgery because it can be reversed during surgery. Phenoxybenzamine also has serotonin receptor blocking effects, which justify its occasional use in carcinoid tumor, as well as H1 antihistaminic effects, which lead to its use in mastocytosis. Accidental local infiltration of potent alpha agonists such as norepinephrine may lead to severe tissue ischemia and necrosis if not promptly reversed. Infiltration of the ischemic area with phentolamine is sometimes used to prevent tissue damage. Okay. So overdose with drugs of abuse such as amphetamine, cocaine, or phenylpropranololamine may lead to severe hypertension because of their indirect sympathomimetic actions. So cocaine, amphetamine, okay, all of these, they have indirect sympathomimetic actions. Amphetamine, if you remember, it was a releaser, and cocaine, it increased its effect by decreasing its reuptake. So this hypertension usually responds to, well to alpha blockers. Cocaine, you remember NET and that, right? So sudden cessation of clonidine therapy leads to rebound hypertension. This phenomenon is often treated with phentolamine. Okay. So overdose with drugs of abuse such as amphetamine or cocaine or phenylpropranololamine may lead to severe hypertension. Even sudden cessation of clonidine therapy also results in hypertension. That is treated with phentolamine. Raynaud's phenomenon sometimes responds to alpha blockers, but their efficacy in this condition is not well documented. Phentolamine or yohimbine has been used by direct injection to cause penile erection in men with erectile dysfunction, but phosphodiesterase inhibitors are more popular, okay, because they associate themselves with camp and nitric oxide release and all that. Okay, so phentolamine, it can phentolamine, again reversible. It is used in surgery of pheochromocytoma, and it is again used whenever there is excessive ischemia and local necrosis because of norepinephrine local injection, ischemia. And phentolamine is again used whenever there is sudden cessation of clonidine therapy. So hypertension due to clonidine therapy, cessation of that, and also sometimes you can use it for penile erection. Okay, so for all these you can use phentolamine. So coming to selective alpha blockers, we have prazosin, doxazosin, and terazosin, which are used in hypertension. Okay, prazosin prime, your heart is of primary importance, so it is used in hypertension. These alpha 1 blockers as well as tamsulosin and silodosin are also used to reduce urinary hesitancy and prevent urinary retention in men with benign prostatic hyperplasia. So finally, coming to the toxicity, the most important toxicities of the alpha blockers are simple extensions of their alpha blocking effects. The main manifestations are orthostatic hypotension, and in the case of non-selective agents, marked reflex tachycardia. Tachycardia is less common and less severe with alpha 1 selective blockers. Phentolamine also has some non-alpha mediated vasodilating effects. Okay, So in patients with coronary disease, angina may be precipitated by the tachycardia. Oral administration of some of these drugs can cause nausea and vomiting. The alpha 1 selective agents are associated with an exaggerated orthostatic hypotensive response to the first dose in some patients. Therefore, the first dose is usually small and taken just before going to bed. So now let's move on to the beta blocking drugs. So coming to the classification, subgroups and mechanisms, all of the beta blockers used clinically are competitive pharmacological antagonists. Propranolol is a prototype. Okay, it is non-selective. Drugs in this group are usually classified into subgroups on the basis of beta 1 selectivity, partial agonist activity, local anesthetic action, and lipid solubility. Metoprolol and betaxolol appear to have inverse agonist action. Okay, so let's just discuss this table here. So, so beta 1 selective drugs, we have A for atenolol, A for acebutolol. Okay, A rhymes with E, so esmolol is also beta 1 selective. Okay, so A, E. Okay, so we also have M, AMA, so AAMA, AMA. Okay, M for metoprolol, which is also beta 1 selective, and if you have M you also have N, but you're just taking N because it has M, right? So beta 1 at low doses only, and so they are the beta 1 selective drugs. The rest are not beta 1 selective. So coming to the receptor selectivity, beta 1 receptor selectivity, beta 1 blockage is greater than beta 2 block, is a property of acebutolol, atenolol, esmolol, metoprolol, and several other beta blockers. This property may be an advantage when treating patients with asthma because functioning beta 2 receptors are important in preventing bronchospasm in such patients. Beta 2 receptors which function are important to prevent bronchospasm. Okay, so beta 2 receptors prevent bronchospasm. Okay, so nadolol, propranolol, and timolol are typical non-selective beta blockers. Okay, nadolol, nada, no, non-selective. Okay, timolol, it's timid to be selective, so it is non-selective. Note that except for beta blockers that start with the letter C, blockers with names starting with letters A through M are beta 1 selective. So that is another way you can remember beta blockers. Labetalol and carvedilol have combined alpha and beta blocking actions. These drugs are optically active and the different isomers have alpha or beta blocking action. What are they? Labetalol and carvedilol. Nebivolol has vasodilating action in addition to dose-dependent beta 1 selective antagonism. Okay. So coming to the partial agonist activity, which is an intrinsic sympathomimetic activity, may be an advantage in treating patients with asthma because these drugs such as pindolol and acebutolol, at least in theory, are less likely to cause bronchospasm. In contrast, full antagonists such as propranolol are likely to cause severe bronchospasm in patients with airway disease. Local anesthetic activity or membrane stabilizing activity is a disadvantage when beta blockers are used topically in the eye because it decreases the protective reflexes and increases the risk of corneal ulceration. Local anesthetic effects are absent from timolol. It is timid, okay, so it cannot stabilize. It is not powerful enough to stabilize a membrane. So local anesthetic effects are absent from timolol and several other beta blockers that are useful in glaucoma. Pharmacokinetics. Most of the systemic agents have been developed for chronic oral use, but bioavailability and duration of action vary widely. So, esmolol is a short-acting ester beta blocker that is used only parenterally. Nadolol is the longest-acting beta blocker. Nadolol, okay. Nadolol, longest-acting beta blocker. Esmolol is short-acting one, and acebutolol, atenolol, and nadolol are less lipid soluble than other beta blockers and probably enter the CNS to a lesser extent. Okay, so because it is less lipid soluble, nadolol is a long acting beta blocker, longest acting beta blocker. Okay, so coming to the skill keeper section, so draw a concentration response graph showing the effect of increasing concentrations of albuterol on airway diameter in the presence of a large concentration of pindolol. On the same graph, draw the curves for the percentage of receptors bound to albuterol and pindolol at each concentration. Let's look at that later. So coming to the effects and clinical uses, most of the organ level effects of beta blockers are predictable from the blockade of the beta receptor mediated effects of sympathetic discharge. The clinical applications of beta blockade are remarkably broad. So the treatment of open-angle glaucoma involves the use of several groups of autonomic drugs as well as other agents. The cardiovascular applications of beta blockers, especially in hypertension, angina, and arrhythmias, are extremely important. So treatment of chronic heart failure has become an important application of beta blockers. Several large clinical trials have shown that some, but not all, some beta blockers can reduce morbidity and mortality when used properly in heart failure, chronic heart disease. Okay, so similar paradoxical benefit of beta blocker therapy has been observed in some patients with chronic obstructive pulmonary disease, chronic pulmonary disease, so COPD. Labetalol, carvedilol, and metoprolol have documented benefits in this application. Pheochromocytoma is sometimes treated with combined alpha and beta blocking agents such as labetalol. We also discussed the use of phentolamine during surgery for pheochromocytoma. So, labetalol can be used especially if the tumor is producing large amounts of epinephrine as well as norepinephrine. So, if there is production of large amounts of epi and norepinephrine because of a medullary tumor called pheochromocytoma, large amounts we use labetalol. A novel and unexplained beneficial reduction in the size of infantile hemangiomas has been reported for propranolol. So coming to toxicity, cardiovascular adverse effects which are extensions of the beta blockade include bradycardia if the reflexes are not working properly, also atrioventricular blockade and heart failure. Patients with asthmatic airway disease may suffer severe asthma attacks through some patients, although some patients with COPD may benefit from careful use of beta 1 selective agents. Beta blockers have been shown experimentally to reduce insulin secretion, but this does not appear to be a clinically important effect. Okay, however, premonitory symptoms of hypoglycemia from insulin overdose because of tachycardia, tremor, and anxiety may be masked by beta blockers, and mobilization of glucose from the liver and sequestration of K plus ions in skeletal muscles may be impaired. Okay. CNS adverse effects include sedation, fatigue, and sleep alterations. Atenolol, nadolol, and several other less lipid soluble beta blockers are claimed to have less marked CNS action because they do not enter the CNS as readily as other members of this group, because they do not cross the blood brain barrier. Sexual dysfunction has been reported for most of the beta blockers in some patients. Okay, so that's it with the chapter on beta blockers. So, local anesthetic activity. What all has local anesthetic activity? You have A for anesthesia, A for acebutolol, but again atenolol says no to anesthesia, no to A, no to anesthesia. And again labetalol has an anesthetic activity. Okay, and metoprolol again has anesthetic activity. Pindolol has anesthetic activity, propranolol has anesthetic activity, timolol does not have anesthetic activity, so you can use it in the eye and the reflexes they will not be impaired. Because reflexes are not impaired, you won't have corneal ulceration if you use timolol in the eye. Okay, so coming to partial agonist activity, if it is a selective beta 1 blocker, it does not have any partial agonist activity. Okay, labetalol has beta 2 agonist activity. And now coming to lipid solubility, we already discussed this. There is low lipid solubility in the case of nadolol and labetalol. Okay, so that is why CNS effects are low. Atenolol, nadolol, and several other less soluble beta blockers don't have CNS effects because they cannot cross the blood-brain barrier. And coming to drugs used in glaucoma, so we have beta blockers such as timolol and others, and they lead to decreased secretion of aqueous humor from the ciliary epithelium. Okay, it is timid. It is not a local anesthetic, so it won't prevent any reflexes that that cause corneal ulceration. Okay, so timolol can be used in case of glaucoma. So topical drops are used. So most of these are topical drops. And now prostaglandins, we have latanoprost and others which increase the aqueous outflow, and they are also topical drops. We have cholinomimetics such as pilocarpine and physostigmine, which cause ciliary muscle contraction, opening of the trabecular meshwork, and increased outflow. And again, they are topical drops or gel or plastic film slow release inserts. So cholinomimetics, right? Acetylcholine. Okay, so if there is choline, from physiology you've been talking about acetylcholine with at muscular end plates, neuromuscular end plates. So you have to talk about a muscle when you're talking about glaucoma and cholinomimetic drugs used in it. So ciliary muscle contraction. So when the ciliary muscle contracts, okay, basically pushing. You can imagine as if the muscular contraction is pushing it out. So there is increased outflow and opening of the trabecular meshwork. Coming to alpha agonists, non-selective drugs, we have epinephrine, which increases the outflow via the uveoscleral veins because it kind of dilates the dilates the pupil. Topical drops again, but it is obsolete now. Alpha 2 selective agonists, we have apraclonidine and brimonidine. They decrease the aqueous secretion. Topical drops. Carbonic anhydrase inhibitors, we have acetazolamide and dorzolamide, which decrease aqueous secretion due to lack of bicarbonate ions. Carbonic anhydrase inhibitors. They can be used orally in case of acetazolamide or topically in case of other drugs. You also have mannitol, which is an osmotic agent. Okay, so it removes the water from the eye, and it is used for acute close angled glaucoma through the IV route. So that's it for this chapter. Finally, coming to the graph, because pindolol is a partial agonist at beta receptors, the concentration response curve will show a bronchodilating effect at zero albuterol concentration. As albuterol concentration increases, the airway diameter also increases. Okay, salbutamol, albuterol. Okay, so the airway dilation also increases with increasing concentration of albuterol. Pindolol again again it sort of decreases the airway concentration. Okay, so the binding curves will show pindolol binding starting at 100% of receptors and going to 0 as albuterol concentration increases, with albuterol binding starting at 0 and going to 100%. So the total effect will be vasodilation because you need albuterol to work to dilate your bronchi.